guys, welcome to another lecture, and today we'll be discussing something about features of renal replacement therapy. And before I begin, I would like to request you to like, share and subscribe to the channel if you haven't already. And we will discuss about renal replacement therapy. So renal replacement therapy is usually used in patients who have either AKI or CKD, who are not amenable, who cannot be treated or not amenable to medical therapy. So you have to, there are complications. Imagine there are kidney complications like drug-resistant hyperkalemia or presence of drug-resistant hyperuricemia or uremic pericarditis or drug-resistant or drug amenable or, that medical therapy resistant volume overload. So then you have to go for the renal replacement therapy. Or the second is in pediatric, especially is inborn errors of metabolism to flush out or to excrete out the toxins that are created, dialyzable toxins that are created, especially ammonia, hyperammoniemia. Ammonia is the primary toxin that we need to flush in IEM. So these two are the common indications of renal replacement therapy. Now today we will be discussing the features of, rapidly we will be discussing and revising the three types of dialysis. So first one is peritoneal dialysis, where the peritoneal membrane acts as a filter. It acts as a semi-permeable membrane. So mode of clearance or mode of action of peritoneal dialysis is diffusion. Okay, it filters via diffusion. And what are the advantages of peritoneal dialysis? So it is comparatively simple to perform. It is very, very simple to perform, and it does not require advanced vascular access. It does not require even home peritoneal dialysis is nowadays available. So it is comparatively simple. It requires a PD catheter and it is a rapid procedure. It does not require operation theater, surgeon, everything. Anyone can do it who is trained enough. So it is simple and can be performed at home. There are no dietary restriction, like you have to just avoid the toxin source, but then technically there are no dietary restriction in these patients. No vascular access is required. No heparin is to be given to the patient and can be used in hemodynamically unstable patient. BP come hai, hemodynamically unstable patient, you can use this therapy. So this is the advantage of peritoneal dialysis. Now, obviously, everything has its own set of disadvantages, and what are they? So disadvantage is that it is slow. Okay, it will not give rapid clearance like hemodialysis. It will take time to remove the toxins out. So that is why the slower onset is there, and rapid fall is not achieved by this method. And second is it is contraindicated in abdominal wall abnormalities, like when there has been a patient with gastroschisis, or you have a patient with congenital diaphragmatic hernia, where you are expecting that the abdominal wall might be compromised. So then, you have a very, very bad setback if you put all this. What are the side effects? So side effects, complications, very, very important. So catheter related, like displacement, catheter displacement might occur. There might be pressure necrosis where you have put the catheter. There might be peritonitis, local site infection, and electrolyte and metabolic imbalance might be occurring. So this is about the peritoneal dialysis, most easy to perform yet most convenient. Okay, so peritoneal dialysis is always, even in neonatology, in pediatrics, we prefer usage of peritoneal dialysis in patients. Hemodialysis. So hemodialysis very, very efficient, most efficient, and it works via diffusion and convection. Both methods are working over here, and it is the fastest and most efficient. Okay, so that is the advantage, but the disadvantage, big disadvantages list is there. First is large extracorporeal volume. What does this mean is, okay, bhai, imagine that there is a newborn and newborn blood volume is, imagine like 100 ml, the blood volume is there in the newborn. So what is the issue is that there will be a nearly same amount of volume that is circulating in the circuit of uh, the dialysis machine. So there are the patient is prone to have issues, because see, x amount ka blood volume is in our body and x amount ka blood volume is outside. So small calculation error or small changes will lead to bigger effects in smaller children, like ELBW hai, VLBW hai, or the low birth weight children are there, or even smaller infants are there. They will have big issues, because even 10-20 ml for a newborn intravenous volume is a big deal compared to us. Okay, so that is why in pediatric, this large extracorporeal volume turns out to be a very big problem if you do not calculate it properly. Then second is calculation error. Calculation error of ultrafiltrate. Again, the same I told you, calculation thoda bhi idhar udhar ho gaya, it will lead to bigger complications. Second is that monitoring, continuous monitoring is required, because patients, many of you who might have worked in a dialysis unit might have seen the patient can decompensate within seconds in front of you, and that is more severe in pediatric, because monitoring is required. Potassium might go, the patient might code, flatline might occur at any point of time if not monitored properly. Okay, then presence of vascular access, like tunneled subcutaneous tunnels, tunnel catheter are formed for these patients, because they require a reliable vascular access that works, okay, with a good amount of backflow. Okay, because the whatever the amount of blood they put inside, they have to pull it outside, and if the catheter is small, if the access is small, if the flow is not adequate, obviously they will reject the patient, they will not do the dialysis of the patient. Second is heparinization, because you have to give heparin to the patient so that the catheter is not blocked. So, heparinization has its own set of side effects. Okay. And blood prime. What is blood prime? So, blood prime means that you have to keep some amount of extra blood in the circuit so that the patient does not go in hypovolemia while the extra blood is flowing through the circuit. So, blood priming is to be done. That is known as blood prime. This should be done if the blood in the circuit is expected to be more than 10% of the total body volume of the patient. Okay. The side effect, complications and side effects are same: migration and thrombosis of catheter. It might lead to hypotension, disequilibrium syndrome. This equilibrium syndrome is a variant where, due to sudden fall in the urea or the ammonia of the body, it will lead to cerebral edema, something like pontine myelinosis, because the solutes are so acutely decreased, the brain will lead to brain edema. So there is a dialysis disequilibrium syndrome seen in hemodialysis. Third and the last way is CRRT. CRRT is continuous renal replacement therapy, where you continuously use hemodialysis as a method so that the acute fall, like big falls or fast falls, are not there, and slow falls are there, slow peaks are there, plateauing is there, so that complications are eliminated. So this can be used in hemodynamically unstable patient. And another advantage is this can be used fantastically with a ECMO circuit. If a patient is hooked to ECMO circuit can be, added to this like a series, the series connection, the series resistant connection are there, something like that. You can add it. Okay. And these are available, different machines like Nidus are also available for even the 800 gram ELBW child. So this is a very good, and nowadays it is gaining more and more popularity. Again, this requires a blood prime. The disadvantage is that it requires a blood prime, it requires vascular access, and it requires heparinization. But sudden changes in volume is not there over here. The side effects or the complications are same. Okay, bhai, there will be the line issue, and there is a bradykinin release syndrome. It initially what happened was that this blood prime that was used, it was severely acidotic. This reacted with the CRRT filter, and it led to huge increase in bradykinin, leading to Redman syndrome like picture where a huge amount of histamine and bradykinin were released. Patient went into hypotension, tachyarrhythmias, and many of them died. Okay, so this was initially, now it is not commonly seen. CRRT mechanism of action, it can be either diffusion or convection or both. Depending upon the machine, there are three commonly used machine: Nidus, Aquadex, and Carpetine. So depending upon the machine, the methods are different, but either it can be single or both of them. So that is what you need to remember. So that's all for today, guys. I hope you learned something new, and I will see you in the next one. Before going, I would like to tell you that if you haven't already, please go on my website, check out my website. I hope you like it, and you download my app. It is available on Google Play Store, App Store, both, and all the links are in description below. I will see you in the next one.